All right, so we have two examples of hypertrophic cardiomyopathy here. Difference is that the one on the left is considered HCM and the one on the right is obstructed, so it's considered what we call HOCM. So let's take a look at the actual difference. And so on the left, blood comes in to the LA, circles around in the LV, and it goes out of the aortic valve. There's thickening of the myocardium here, but it's not obstructing the blood flow from going out of the aortic valve. Whereas on the right, the thickening is placed right at the center of the LVOT. So the blood comes into the LA and circles around in the LV, but can't quite get out of the aortic valve, making this very dangerous for your patient because they're not getting oxygenated flow. And not every time will this be quite obvious. As we all know, the endocardium can be pretty difficult to see sometimes on some patients. And so if there's thickening or a piece of the wall that is thicker than others, and you aren't cutting it just right, maybe you can't see it. So another way to identify this is what we call the dagger-shaped waveform. And so when you throw your continuous wave Doppler through your aortic valve, your normal waveform is going to look like this, right? But in a patient with HOCM or HCM, either one, you're going to get what we call a dynamic gradient. And that's this dagger-shaped waveform here. And it's what we call a late peaking waveform, because instead of it peaking right in the middle of systole, it peaks at late systole. And that's because as this ventricle squeezes and squeezes and squeezes, the LVOT right here gets narrower and narrower due to the thickening of the wall here. And so as this space gets tighter and tighter, as the LV squeezes, you have a faster and faster velocity as systole continues on. So you get your highest velocity at the end of systole. So if you see the dynamic gradient on your echo, your next step is to do what we call pulsing down the cavity. So you got your dynamic gradient on continuous wave. Next, you're going to take your sample gate and you're going to pulse down it. So you're going to pulse here, you'll get your normal waveform. Pulse here, normal waveform. And you'll keep doing this until you get to the area, which is probably going to be about right there on this example, which is going to give you your dynamic gradient. But because we know pulse wave will tell you a specific location, whereas continuous wave takes the entirety of that line, right? So this is just telling the doctor, this is exactly where that gradient is coming from. This is where the issue is arising. And lastly, once you find the location with pulse wave, you'll do the same thing. You'll pulse in that specific area, but then you're going to have your patient Valsalva. And what do we know Valsalva does for our patient? Valsalva is going to increase right-sided pressures. It's going to decrease your venous return. Which inevitably is going to decrease your left-sided pressure. And it will decrease the amount of volume overall in the heart. So what's happening is if you have an increase in pressure over here and a decrease in pressure over here and an overall lower blood volume going into the heart, this LV cavity is going to start squeezing harder in on itself, right? Less volume, lower pressure, those walls are working hard. You start to get a higher ejection fraction, meaning that this velocity here is going to be much higher now because you have a harder squeeze, you have a higher velocity. So instead of this hitting around 2 meters a second, now it's going to extend all the way down here, and it might give you 3.5, 4 meters a second. So it's just going to exaggerate this waveform and tell you the worst possible scenario of what this patient could endure.